Check, mic 1, okay?
Good morning, everyone. I am Tony Baker, the Division Chief for Pay and Benefits. I'd like to welcome everyone to our workshop this morning on Health Benefits 101. I hope today will be beneficial for each and every one of you here at CMS proper and out in the regions. So spend no time not asking questions. If you have those questions, ask them today. Don't stall, because this is all about you. It's not about us, it's all about you. The more information we can give you, the better off you are in your planning phases for your future with your health and your benefits. So please pay attention today. A lot of information is going to come at you. We have some great presenters, and I know that they will spark your interest and take you on a ride of strategic thinking for your future. So without further ado, I'd like to introduce Paulette, who will be the host for today, and I'll get out of the way. Less said, better done.
All right. Thanks, Tony, for that warm welcome on this morning. I want to echo Tony and welcome you all to our fourth Stay on Top of Your Federal Benefits Educational Seminar. We have a host of seminars scheduled for 2014, so this is our fourth one, and we have a couple of more to go throughout the year. So we want you all to make a note of that and just be on the watch for our other seminars. Today, we're going to be talking about your federal employees' health benefits plan. And as Tony indicated, we have a host of experts here today with a plethora of information on your health benefits plan. So you are going to gain a wealth of knowledge, and that's going to arm you to make some very, very important decisions around your health benefits plan. Before I get started and introduce our speakers on today and bring them forward, I do have some administrative notes that I need to bring to your attention on this morning. First, I wanted to let you all know, for those who are on the phones, we're asking that you please put your phones on mute for us, and because that's going to help us with the noise, the feedback, and distractions. So if you would please make sure that your phones are on mute for us, that would be very helpful. The second item that I have is our survey questionnaire. We're asking for you to please complete the survey questionnaire. And for those of you who are here in person, you can provide the questionnaire to our benefits experts who are sitting outside, right outside at the tables. For those who are online, and for those of you who are streaming today, you can request a survey questionnaire from the HR Center Help Desk, and I will give you the email address. It's hrcenterhelpdesk@cms.hhs.gov. So just go right online and request one, and complete it and return it for us. That's for our regional offices and our outlying office employees who are online. The next item is the questions and answers. And we will be having a fire drill on today, as most of you are aware. It's scheduled for 10 o'clock this morning. So we're going to have to exit the building around 10 o'clock. And I have a note here that we are supposed to assemble at Assembly Area 19. For those of you who may be here from the North Building, the fire drill is for the folks who are in the central office, but because you're here for the seminar here in the auditorium, we're going to assemble at Assembly Area 19. So that's where everyone is going to be going. And we just wanted you all to make a note that we will have a fire drill. So once we break up due to the fire drill, after the fire drill, we're going to resume. We're going to come back and pick up where we left off at, and we will be here until 12 o'clock. Also, the benefit plan experts, they're going to be here all day because we have another event from 1 o'clock until around 3 today where it's our health benefits service day. So they're going to be hanging around all day. So if you don't get to ask your question on today during the segment that we're having on this morning, you can hang around and ask your question after the presentations on today. We're looking to get finished around 12 o'clock on this morning. And if you hang around, they will be here. You can ask questions up until 3 o'clock, okay? That's for those of you who are here. So what we're going to do is, for the questions, for those who are online, we're going to give you an opportunity to ask 1 or 2 questions after each segment. That's for the presentation on today. After each segment, you will get to answer. We will take 1 or 2 questions so we can kind of keep things moving and kind of make up for the lost time due to the fire drill. So does that make sense? Okay, great. All right, so without further delay, what I would like to do is to bring up Mr. Bill Gray. He's going to come forward and he's going to facilitate and introduce all of our expert panel that we have on today. And again, you all sit back and just take what you can on today, and hopefully that will help you prepare for your upcoming open season for making selections on your benefit plans. So without further delay, I'm going to bring forth Mr. Bill Gray. And let's give him a warm CMS welcome.
Good morning. Thank you. What we'd like to do first off is, first I'll let you know who's here. I'm Bill Gray with Care First Blue Cross Blue Shield. And from GIHA, we have Tamika Anderson. From United Healthcare Vision, we have Sue Unger. From United Healthcare Medical Plans, we have Ryan Hargist. From Kaiser Permanente, we have Christelle Bull. From Aetna, we have Sekou Mitchell. From Mail Handlers, we have Kelly Pinton. And from Long-Term Care Partners, we have Linda Anderson. So we do have a range of FEHBP, FEDVIP, long-term care, dental vision, all will be talked to in some detail today. We'd like to start with giving you an idea of, let me go forward again, what you're facing when you look at health cares. During open season, you have this night website, opm.gov/nowhealthcare. I keep saying insure, but now healthcare. The website lets you know that my zip code, just to give you an idea, is go in with your zip code. I'm 21030. There are 33 health plan options offered by 15 different carriers. There are 13 dental options offered by 8 different carriers. And there are 8 vision options from 4 different carriers. You have a lot of choice, much more than any other employer I've ever heard of. Your rates for the medical are 2-tier at the present time. You're either individual or you're a family. With the FEDVIP, you have individual, self plus one, and family. For the medical, the government pays 70 to 72% of the premium. For the dental and vision, pardon me, the employee pays 100% of the benefits. Dependent children, as you all know, you can cover your dependent children up to age 26, whether they're married or not, whether they're in the house or not, you can still cover them. Whether they have a job or not, they can still be on your coverage if you have family coverage. Dental and vision, they still come off when they turn 22. So there is a difference there in that respect. And medical plans do provide some dental and vision. It may be a discount program, it may be preventive only. But if you have a 23-year-old child, they need to get glasses, check the medical plan, see what they cover. So you do have those options. When you retire, certain things you should keep in mind. Get real quick, get FEDVIP out of the way. Don't worry. You can pick it up whether you're active or retired. You can pick it up at any you can pick it up at any open season. You can drop it at any open season. There's no requirement that you be in 5 years. But for medical, you must qualify for retirement. You must take an immediate annuity. And when you go into retirement, you must have had a federal plan for at least 5 years. It could be Aetna 1 year, GIHA the next, any other care. You can have a different care each of the 5 years. but you must have a medical plan 5 years in retirement. If you are retired military or the dependent of a retired military, and you have TRICARE, that's coverage through the government, through the military, that counts towards the 5 years, as long as you're carrying TRICARE at your carrying FEHBP at your retirement. And if your spouse is not a federal employee, you must take an immediate annuity for that spouse to have coverage if anything happens to you. If your spouse is a federal employee, otherwise qualified for retirement, he or she, if anything happens to you, can pick it up on their own because there's no break in coverage. While they were on your coverage, it counted. The same applies towards the 5 years. You're both federal employees, the husband carries the coverage, doesn't matter. The wife is still counting towards her 5 years. Dependent children, went through that already. Whoops, went backwards. Okay, active employer dependent, the penalty, if you are an active employee turning 65 and you do not take Medicare or you're just dependent of an employee who has active coverage, you will not be penalized if you turn down Medicare B at eligibility. If you're a retiree or the dependent of a retiree, then there's a 10% penalty added on to your Medicare B rate if you take it later. And different than any other employer I'm aware of, to include the military, you are never required to take Medicare. So you have the option. So to be or not to be, should I take Part B or not, is a totally different topic, totally different meeting, but we can go through how to make that decision and how to approach it. And if you are retired and you're entitled to TRICARE or you choose a Medicare C carrier, then you can suspend your coverage. That means go off the FEHBP, only use TRICARE or the Medicare C package as a retiree, and then the next open season come back in again if you want to. That's not cancellation, that's suspension. Okay, FEDVIP plans, different. No 5-year requirement, and if you lose the coverage or your dependent turns 22, they cannot pick it up on their own under temporary continuation of coverage. You can continue the medical. This is only the dental and vision. And you can pick up or terminate any open season or life event. What are the differences in the type of plans? We see acronyms, we see abbreviations. Fee-for-service, or FFS, are the national or international programs. They are mostly PPOs, preferred provider organizations. Bottom line is they contract with providers. And you'll pay less if you use a contracted provider, and they will cover you no matter where you are for routine care. Regional plans can be various types. They can be HMO, Health Maintenance Organization. They can be consumer-driven or high-deductible health plans. They would be, for example, in the Mid-Atlantic region. We have several here. If you want to know where I can get routine care under my carrier, that's defined in your brochure under service area. There's a brief description on the front of the brochure. There's more detail, in some cases includes zip codes, that tells you anywhere listed in here I can get care. Doesn't mean that if I have a regional carrier and I have emergency condition anywhere in the world, there's no coverage. There is. Emergencies are covered anywhere in the world. Some regional carriers have affiliates in another state, in another region, where if my child goes to school or I'm on TDY, you can make an arrangement to have covered through their affiliate. You need to check their brochures, give them a call, and find out if that applies. This is opm.gov/healthfare. And the first thing up here is the FEHB handbook. One example. There's also one for health benefits. You don't have to get the paper anymore. You can download it on your device. It's one way to have a handy reference that you can find. When you go in there, you'll find things like long-term care, medical, flexible spending accounts. This is the healthcare page. When I chose 21020, I went to Maryland, and I can compare all the plans in my area. The program allows you to get, with the medical, When you go in, there's a little box that says include FFS. That's those international plans. If that box is not checked, you'll only get the regional plans. So when you go to the website, make sure the box is checked. You can scan the list and you can pick up to 4 carriers. You can do the same thing for dental, same thing for vision. With the medical plans, you have the option to request additional information. This is a little bit of what it looks like when you go in. Some of the key terms, catastrophic limit. That's the most for usually in-network care, the most you will pay out of pocket in a given calendar year. The brochure will tell you what is not included. In-network, essential benefits are always included in the catastrophic limit or out-of-pocket maximum. It tells you the calendar deductible. The basic information is here, and you can put plans side by side. When you go into this is the dental vision, just to give you an idea. This is a vision plan. The vision plans are national, and this gives you an idea how one plan may differ from another. It's an excellent tool to see where's the variation, where's the differences. This is dental. Little thing about the dental. If you live in Maryland, across the Bay Bridge, your premium may be different from someone who lives in Anne Arundel County. So you really need to check this out because depending upon where you live, it will tell you which level you pay, what your premium actually is. So this summarizes very briefly based upon your zip code. This is your private comparison of several dental plans. There's something called a Summary of Benefits and Coverage, or SBC. I work for the federal government. My wife works for the state of Maryland. How do I compare the benefits? Everybody under the Affordable Care Act has to have an SBC. Somewhere on the web page or through the employer, these are usually, the government makes us put them on the web page, you can find what a Summary of Benefits and Coverage gives you. It's similar language, similar usage. It also gives you a chart, if you're a diabetic or you're pregnant, of seeing how the calculation that everybody has to use, how much you might pay out in a given calendar year if you're pregnant or you have diabetes. Only thing I don't like, it always assumes the deductible applies, and it might not. But it does. But each carrier has to compare the same way. It's another tool. It's extremely useful. Okay, fee-for-service plans. I'm going to turn it now over to Tamika, and she will take you through fee-for-service plans.
Good morning. Again, my name is Tamika Anderson, and I represent GEHA, that's Government Employees Health Association. And today I'm just going to give you some of the main highlights of the FEHB facts for fee-for-service plans, which is also known as PPO service plans as well. These fee-for-service plans provide you with worldwide benefits for routine care. Normally, they provide out-of-network benefits as well. So you get to use providers in-network and out-of-network as well with fee-for-service options. They do have a deductible and co-insurance that apply to some services in-network, and they apply to all out-of-network services. You usually pay less money out of pocket when you stay in the PPO provider network, being as though that the health insurance company has a contract with that provider or the specialist or the hospital. When you're visiting a PPO provider as well, usually you won't have to manually file any of your claims because they have the capability to file these claims on your behalf electronically. And going to PPO hospitals does not, however, guarantee that all your benefits for services that are rendered within that hospital are going to be covered under the PPO agreement. For instance, if you get lab work or radiology services from independent practitioners within that hospital, they may not necessarily be covered under that PPO hospital agreement. So you want to keep in mind you may actually have some type of out-of-pocket cost on the back end if that actually happens. Most of our networks, from carrier to carrier, has a quite wide network. For example, we have over 1 million providers at GEHA nationwide that is available to you, but not all of everybody has all your doctors or hospitals that you want. So again, like I said, staying in the network will be a very great cost savings to you on the back end. And also, there are PPO options only. And with this option, you must use PPO providers to get your benefits. So again, I like to stress that if you do choose a PPO option, there is a PPO only network. You must use their providers to get the benefits. If your doctor's is in network, your lab and your x-ray services performed in their office facility are in network as well. So again, and you won't have any paperwork for in-network services to file on your behalf for services if you stay within their PPO network. So lastly, I'd like to compare some different types of fee-for-service plans, some options that may come up as you want to take a look at fee-for-service options and are making a choice. Again, you can compare all of these at opm.gov/healthcare. So one, if you actually are in a fee-for-service plan and you do not use PPO providers or one is not available, say within a certain radius, you will generally pay more when you get your care. And the out-of-network preventative health care services may also be subject to your deductible. You may potentially have to file your claims for service mostly all the time in this particular instance. Next, if you're in a fee-for-service plan and you use the PPO in-network providers, hospitals, and doctors, you generally will pay less. Again, like I said, I can't stress that even more. And then your preventative care services are not subject to any cost sharing if you stay within the network. And again, you have little or no paperwork to file because all of them actually have signed an agreement with all of us carriers, and they can file those paper claims electronically over to us. And lastly, if you are in a fee-for-service plan, and again, like I said, if it's a PPO option where you have to utilize those doctors and those hospitals in that option, you must use those network providers to get the benefits. Now, if there's not a provider or hospital within a certain radius, there are exceptions that may be made for you. And generally, you will pay a co-payment base with these PPO options, and it won't be subject, you won't have any deductible. And then again, you will have little to no paperwork to file your claims or anything like that. Like I said, with the other options, sometimes you use a non-provider and they won't file the claim for you, so you do have to keep a copy of your itemized bill and go onto our websites and download that claim form and submit that to us so you can actually seek reimbursement for the services under that agreement. But again, like I said, take a look at the physician networks, the specialists, and the hospitals from whom your health plan contracts with, because that's where I said that's where you're either going to get the most bang for your buck, as I like to say, or have to pay a lot on the back end out of pocket. So those are some of the things we'd like you to keep in mind. So without further ado, we're going to keep the presentation rolling, and I would like to introduce Sekou Mitchell, who's going to come up from Aetna, and he's going to speak to you about the CDHP plans and the high deductible health plans. So Sekou.
Before we move to Sekou in 10 o'clock, are there any questions anyone has on what I've said so far? It's a lot of info, and what Tamika has said. Yes, ma'am.
The other question, I didn't understand it maybe because I came in a few minutes late. You said you had to be an annuitant or take an annuity. What does that mean? Oh.
The idea was if you take your benefits into retirement, and when you retire, you don't take an immediate annuity. You defer an annuity, you might not be able to take your health benefits into retirement. It comes out of your retirement pay. your retirement pay. That's how to take benefits into retirement. Okay. Yes, ma'am.
The rates for three-tier, I understood the self-family and self-family. What's self plus?
Okay, we get started again, please. The question we had before we broke was, what is Self Plus One? On your rates for medical, at the present time, you can get coverage as an individual or a family, even if it's only a husband and wife or a parent and child. Under the vision right now, you can get that Self Plus One, but you can't with the medical. In 2016, there are plans to have a Self Plus One rate for medical, but it won't be, it's not this year and it won't be next year. Okay. Now we're going to continue. Yes, ma'am.
The question I have, since you're on that note, under the dental and vision plan, when you retire, are you to get can you continue on the plan that you're on?
You have the same options with vision and dental that you have with medical. You can change every open season. In addition, you can drop the dental and vision, then pick it up later with no penalty because there's no 5-year requirement, and even in retirement, you can pick it up and drop it each open season. Your medical, if you drop it, you cancel it, you can't come back in again as a retiree. So there is a difference in that 5-year rule and whether you drop it as a retiree. Okay, now we'll move on. Next up would be Brian on the HMO. The gender on the front's a little off. It'll be the HMO, then we'll have the information on the CDHPs. Thank you.
Good morning, everybody. As Bill said, my name is Brian, and I actually represent United Healthcare, more specifically the MDIPA HMO. And what I want to do is talk to you for a few moments about the types of HMOs that are available to you under the federal program. First, let's make sure we all understand that an HMO is a type of managed care organization. And it's a type of managed care organization where your health care is being delivered by a defined network of doctors, hospitals, and other medical professionals. Typically, there are different types of HMOs, which include staff, individual practice association or IPA, and open access models. Now, a staff model is also known or referred to as a closed panel HMO because only the members of the health plan can see these doctors. Medical providers are employed by the health plan or by a group that is hired by the health plan to provide health care services under this type of model. Medical services like diagnostic care, your pharmacy, your specialty care, these services are all typically provided in a centralized location, such as a health plan center. And all care except for emergency care is provided to the health plan member by the staff physicians or other staff medical professionals. IPA, or Individual Practice Association, is another model of an HMO. With the IPA, the doctors are not hired by the health plan. They're contracted by the health plan to provide care for the health plan's patients. Typically, this type of model provides a larger network of doctors because of the contracted situation. Medical services aren't typically offered in a centralized location in the IPA model. Rather, you're going to go to the doctor's own private practice, his or her own office. Now, some doctors do work or pair together in groups, but typically you're not going to find all the services all at one location. Under the IPA model, each member chooses a primary care physician, a PCP, and it's the primary care physician's job to coordinate the member's care. It's also their job to refer them to specialists. Under the IPA model, primary care physicians are usually paid by what we call capitation. That is to say, the doctor gets paid once a month for each patient of the health plan that's on his roster. Regardless of how often that member sees the doctor, that doctor is still getting the same flat amount of payment each month. Then open access is another type of HMO that you can choose from. They are similar to IPAs in the way that they contract with the doctors as opposed to employing them. The primary care physician in this case doesn't have is quite the same role, which means you may or may not, under an open access model, even have to choose a primary care physician. There are no need for referrals under this type of plan. Members can refer themselves to other specialists that are within the HMO network. And under this type of plan, providers, such as the primary care doctor, are usually paid by fee for service. That is to say, they get paid when the service is provided to the member. Now, there is a distinct value in having a primary care physician. They're the member's health care coordinator and the health care advocate, for that matter. They also are responsible for monitoring the patient and staying with the patient in terms of overseeing the care that the patient's being provided, not only by themselves, but by the other specialists and medical providers that are in the network. The primary care physician is the medical professional who is helping the member find the most appropriate care and the most appropriate specialist for that care. And they do help the member to overall achieve their best health. So a few things that may be myths about HMOs that I want to clarify on this slide. First, HMOs only allow members to receive in-network care. Well, this is true to a degree, but certainly not completely true. In any emergency situation, the member is going to go to the nearest emergency room, whether that's in the service area or whether that's away on travel, business, what have you. You're going to go to the nearest emergency room in an emergency situation. Also, if you as a member have a need for highly specialized care, so specialized that there's no provider within the health plan network that can provide that care, then oftentimes members can get an authorization to go outside the network to get that care somewhere else. Next, HMO physicians are rewarded when they successfully provide the least amount of care possible. This is not true. Doctors and other medical professionals are rewarded when they provide the most appropriate care that is provided in a manner where quality and efficiency standards are met. So it's not about the least amount of care, it's about the most or appropriate care where quality and efficiency are the guidelines here. HMOs don't provide the same quality of care available under traditional fee-for-service plans. This, too, is not correct. As a matter of fact, HMOs subscribe to various rating organizations such as NCQA, which stands for the National Committee for Quality Assurance. Think of NCQA as consumer reports for HMO plans. And HMOs strive to get the highest ratings, the highest rankings possible from organizations like NCQA. It provides bragging rights. It is also a form of advertising to say, hey, potential member, please come to us. We've proven, because NCQA or another organization has shown us to provide the best care possible. Some HMOs plans incorporate deductibles and coinsurance as part of their benefit structure. Now, this is true. Over the year, HMO plans have evolved. And through this evolvement, some plans now do require members to pay a deductible or a coinsurance as opposed to just a copayment. This is to help create more affordability in terms of premiums. So the last slide regarding, or at least the last slide in my presentation, is an HMO right for you? That depends on certain factors, including do you already have an affiliation with a specific doctor? And is that doctor within the HMO's network? Do you prefer making one payment per visit rather than being responsible for being charged or itemized for everything that's involved in that visit, whether that be a doctor's visit, an outpatient visit to the hospital, or even an inpatient stay? Usually with HMOs, one copay or one payment covers the entire visit. Do you prefer going to a centralized location for most of your medical needs? Again, this is more on the lines of a staff model HMO, but if you prefer that type of convenience, then an HMO might be right for you to consider. And finally, and this is in general terms, do you prefer lower out-of-pocket costs over increased flexibility? So these are some things to consider during open season when you look at the various HMOs that you can choose from. Crystal, I think you're up next to talk a little bit about other aspects of HMOs.
All right, thank you. Question? At the end? Or no? Okay. All right, good. All right. Good morning again, and I'm Christelle Bull with Kaiser Permanente. I'm very happy to be here today. So Brian just gave you a very good overview of all the different types of HMOs, and I will focus on the staff model plan, basically what we refer to these days as integrated care. So basically, you have this nice chart here that shows you the whole concept of all the different providers, pharmacists, nurses, lab technicians, everybody being a part of the same medical group, sharing the same information about the patients. So basically, the patients would be able to pick their doctor again, but it will have to be within that specific plan or staff model, and going from one doctor to the next within that specific network, going from one specialist to the next, everybody already knows what's happening with you as a patient because there's shared information, typically through technology. You're looking at really extensive electronic medical records where the different providers are able to look at their patients' lab results, notes from different doctors, and coordinate the care that way. It's typically called integrated and coordinated care. That's where this coordination comes into, where conference calls are being held to discuss the patient's care, or emails are being sent back and forth, not only from the member to the doctor, but between the different doctors, between the nurses, which can really help with the outcome for any given, medical issue. So, and also there's the convenience of having a lot of services under one roof. Now, like we mentioned, this may not be for everybody, but for a lot of people, there's a great convenience right there, where these type of models will have various specialty, pharmacy, labs, all located under one roof. So really, we're looking at saving a lot of time and money, not running around town for different things, having everything in one location, being able to take less time off of work, because so many things could be done under the same location really fast. So, so the integrated services, like I mentioned, so basically, look at it this way. It would be health plans where the medical group and the health insurance are one and the same company. They all work together. So there's really no need to be filing claims unless you're out of the area and something happens, and we will cover you, but then you need to file a claim and so forth to get reimbursement. Typically, day-to-day care, you will not be getting bills in the mails or need to file any claims for your routine care, your regular visits, okay? So, and then there's a lot of pharmacy management, case management, where because of the technology and because of the fact that they have all the information centralized in this secure system, they're able to pull up databases and lists of people maybe that have not had their mammograms, and then all the nurses will call on them, or they may be able to see, Dr. XYZ patients have not done their colonoscopies. They can do these outreach calls, again, because of the technology that supports that. And then there's also a lot of additional services that can be provided, classes, education about diabetes management, living with high blood pressure, again, provided at those locations, and typically nurses or doctors working for the plan will be the ones teaching those classes. All right, so, and then there's a lot of wellness coaching as well, some of it done online, some of it done through the phone. People that are trying to quit smoking, they can call, they can log in, and they get all that extra support from this team approach system. So again, thank you so much for listening. Thank you for not falling asleep on me. And basically, any questions for Brian or myself or anybody? Yes?
And Medicare picks you up, you're already under the HMO. What are the changes that goes in between those layers?
Very good. Well, that's an excellent question. Basically, what will happen, first of all, you want to look at your plan that you have, and each plan will handle Medicare a little bit differently. I know some plans, I can speak for what I'm familiar with, where there would be like a Medicare Advantage plan that people can switch to once they pick Medicare. And then what will happen is they will end up having to pay two premiums: their regular premium that they pay for their FEHB coverage and the Medicare B premium. And then on top of that, what will happen, a lot of the co-pays and out-of-pocket expenses will be waived. So, but it's a personal decision. Each person has to look at their health situation. Like if somebody has diabetes and kidney disease, definitely they might want to look at doing that. But, you know, it's a personal decision. We can't really say, okay, you should do this or you should do that. When that time comes, you know, we have usually all the plans have a lot of comparison tools where people can look and see what would make the most sense for them, you know, based on their financial situation, their current health situation, and so forth. But typically, you're going to be looking at picking up the Medicare and then having a lot of the out-of-pocket costs reduced. Any of my experts would like to add on to that? Where's Bill? We lost Bill. Oh, there. Sorry.
What will happen is normally if you have what most of the HMOs do now, if you stay with their program, is they treat Medicare as another insurance. That's normally the standard, which means the most you'll ever pay is the Medicare B deductible. With the PPOs, most of them waive Medicare deductibles and copays, different language, which means is they pick up all the balances after Medicare. You have only your pharmacy copays. That's pretty much the way it is now. I'm going to look at Sekou and Brian. We're pretty much that way. It's not Medicare is another insurance, right? When it's primary. Coordinate the benefits. Yes. We don't waive the copays, but we pay the less of the balance and what we would have paid anyway.
Well, that again, the stress that every plan is going to work a little bit differently. Specifically for MDIPA, we coordinate benefits and we do waive the copays after you've met your Part B deductible. So it's really going to depend. And this is A, assuming obviously you have Medicare A and B, that you are now a retired employee as opposed to an active employee. It's the point that you become retired that Medicare becomes primary and your FEHB plan becomes secondary.
Yeah, the most you would ever pay is the Medicare B deductible. You could pay less, depending upon the carrier.
All right. Any other questions on HMOs or anything else at this moment?
Okay, we're gonna we have some folks on the phones.
Oh,
so,
okay, very good.
Danielle, do we have anyone who has any questions? We will take one from the folks on the lines.
If you have any questions at this time, please hit #5. Again, #5 for questions. If you have any questions over the phone.
Okay, we don't appear to have any online, so we'll move forward.
Okay, so I'm going to talk about my last slide before I turn it over to Sekou Mitchell. So, so basically, you want to be an informed, customer. Make sure you compare. Okay, I think we've all said this. You have all these choices; they're all excellent. Somebody that's perfect for you here may not be perfect for you on this side. So compare, compare, compare. So again, opm.gov/ I believe it changed, healthcare, opm.gov/healthcare. So, you want to compare. So basically, some of the main differences before we go into what Sekou will talk about, you belong to an HMO if you have, pretty much you limit it to the doctors and the providers that you can use, okay? So you're going to be saving a lot of money. The quality of your care will not be compromised, but you just have to make sure you stay within that specific network. So if you're comfortable with that, then it will be good for you. And then in terms of paperwork, it's going to be so easy to use. You're not going to have to keep up with, claims and submitting reimbursements and all these type of things. It will be easy to use. Okay. You belong to a POS plan and use only the providers that are in the network. So again, when you have these limitations on the provider network, it translates into lesser costs, okay? You will still get the full network benefits and the full coverage, but you will pay less, and you will have also little paperwork. Now, you belong to a POS and do not use network providers. So, you decide, again, that, hey, I want to see Dr. XYZ, not out in the network, but that's who I want to see, and that's just fine. Just know that you will most likely pay more when you receive that care. And then some of the services may not be even covered at all. So you may end up paying everything out of pocket. And typically, you want to stay on top of things because you will have all that paperwork. You will have to file claims and so forth. So lots of choices. I think a little bit of everything to suit everybody's needs and preferences. All right. So thank you so much. And I will turn it over to Sekou, who will talk about some other stuff.
Thank you so much. Again, my name is Sekou Mitchell. I am here representing Aetna. But I want to kind of start out by saying that I want to talk to you guys about these plans in layman's terms. As Bill talked about, you have over 33 plans to choose from, not to mention all the standalone vision and dental plans. I want you guys to really start thinking about making your healthcare decisions with this, your wallet or purse. That is what you want to do. You want to save as much money as possible, but you want to get quality care. Today I'm going to talk to you about two plans that are really hard to articulate in 30 seconds or less, but there are some real benefits to these plans. And I'm going to break it down and give you kind of the technical definition of it, and I'm also going to kind of give you some examples so that you can kind of see how they work. And the two plans I'm going to talk about today are called the Consumer Driven Health Plan, or CDHP, and that plan has a fund attached to it, a medical and dental fund. The fund is called a health reimbursement arrangement. And these plans are PPO plans, first and foremost, PPO network plans with funds attached to them. And we're going to talk a little bit today about how they work. And we're also going to give you some examples for you to do some self-assessments to yourself to see whether or not you fit this bucket for this particular product. I'm also going to talk to you about high deductible health plans, or HDHP. Those plans have a health savings account, which is a lot different than your health reimbursement arrangement, and we'll talk about that. And if you have any questions, please let me know. That being said, the consumer-driven health plan describes a wide range of approaches to give you more incentive to control the cost of either your healthcare benefits or healthcare. You have greater freedom in spending healthcare dollars up to a designated amount, and you receive full coverage for in-network preventive care. In return, you assume significantly higher cost-sharing expenses after you've used up the designated. Sorry about that, I didn't move forward so you guys can read along. The catastrophic limit is usually higher than those common in other plans. So let me break it down for you a little bit so you can understand how this plan works. As I mentioned before, the consumer-driven health plan is a PPO plan with a medical fund. Now, this is how it works, and it's real simple. Think of it in 3 steps. You have a deductible, you have coinsurance, and then you have what your plan pays. Now, if you choose a consumer-driven health plan, you typically will have a fund, and under your medical fund, the carrier, be it Aetna or any of the other plans that have the consumer-driven health plan, they give you money up front to spend on your sick visits. You don't get to step 2, which is your deductible. I'm sorry, and I kind of did that wrong. It's your medical fund, dental fund, deductible, coinsurance. The 3 steps are this way. That medical fund is for you to spend on your sick visits. If you don't use all the money in that medical fund, all the remaining amounts roll over to the next year. So I'm just going to use a round number. If you had single, for example, and you had a medical fund, if you have $1,000 in that calendar year, and let's just say you used only $200 of it, well, then you're going to have $800 roll over to the next year. So if you had that in 14, in 2015, you're going to get another $1,000, and you would have $1,800 in your medical fund. Now, conversely, if you use that medical fund, you go back into your deductible phase. So just like any normal fee-for-service or PPO plan, if you incur a claim, you have to meet a deductible. Those deductibles are slightly higher, and in most instances a lot higher than your traditional PPO plan. Using round numbers as an example, your deductible may be $1,250 for single. It could be $2,500 for family. So the deductibles are a little bit elevated versus a common PPO plan. As you go through that medical fund, you get to your deductible phase. Once you pay your deductible, you're in the coinsurance phase. Most coinsurance plans, and they vary from plan to plan, it's either 85-15 or 90-10. So your medical plan would pay 85% of whatever the bill is, and you'd be responsible for a 15% coinsurance. And that's very similar to if you have a traditional PPO plan. Let's just say you went in the hospital, heaven forbid, but you did, and you had a nice hospital bill, and your plan is going to pay 85% of it, and you'd be responsible for the 15% coinsurance. So why would you choose that plan? Well, if you're sitting there and you can make a self-assessment and say, hey, I don't go to the doctor that often. I may go get my flu shot. If I get a cold from somebody at work or the flu or something like that, I may have to go to a ear, nose, and throat doctor, etc. Then if I'm a person that would I consider myself as someone that doesn't get sick a lot, then I might look at this plan. It's a cost-sharing plan. It's a plan that gives you money up front so that you don't have to open up your purse or wallet first dollar. So let's just use the opposite example. Let's just say I'm a person that I go see a lot of specialists, I'm on maintenance drugs, I go to the doctor a lot. Well, as I mentioned, those plans have higher deductibles. So if you fit that category, you may say to yourself, you know what, it may not behoove me to go in that particular plan because you're going to spend a little bit more on the deductible side and your exposure is going to be greater. So it's really something that you have to really do a self-assessment and see where you are. And you should do that anyway. Less than 5 to 6% of federal employees change their plans from year to year in open season. And most often what we tell folks is it's your money. Your healthcare needs are going to change from year to year. As my colleagues mentioned, there are different products that can actually give you money back. You have to ask yourself every year when we do our budgets, when we see what we have to pay for the coming year, you have to do those self-assessments to see whether or not I'm in the right plan, or maybe I could take advantage of a plan like a consumer-driven health plan and have money up front and keep my personal wallet closed when I go to the doctor once or twice a year and accrue money over time. Many carriers have limitations in terms of how much money that you can have in that particular fund. My carrier, we cap you at $5,000 for single and $10,000 for family. So if you were in this plan and you had a couple years where you were really healthy and something happens, you go on vacation, you get into an accident, ski trip, whatever, you may not open up your personal wallet because you would have accrued money into your medical in your HRA. So that's one thing about that plan. I'm going to talk to you about a high deductible health plan. Oops, I went back instead of forward. The high deductible health plan is a health insurance plan in which enrollees pay a deductible of at least $1,250 for self-only coverage or $2,500 for family coverage. The annual out-of-pocket amount the enrollee pays can exceed $5,800 self-only and $11,600 for family coverage. HDHPs can have first dollar coverage, no deductible for preventive care or higher out-of-pocket co-payments, and co-insurance for services received from non-network providers. HDHPs offered by the FEHB program establish a partially funded health savings account for all eligible enrollees and provide comparable health reimbursement accounts, HRAs, for enrollees who are ineligible for HSAs. The HSA premium funding or HRA credit amount varies by plan. Now that last bullet point, I want to kind of start there. There are some things that could happen to you that would make you ineligible to have a high deductible health plan. There's a couple things. You cannot have a full-blown flexible spending account and a high deductible health plan together. The IRS considers that double dipping. However, you can have a limited flexible spending account, and that limited flexible spending account in layman's terms is vision and dental. So you can have both of those. And the last part of that bullet, you cannot be on Medicare and have a high deductible health plan. If you are, let's just say you're on a high deductible health plan and then you came up on 65, you got in your Medicare age. Once you do that, your health savings account is converted into a health reimbursement arrangement, which is very different because your health savings account, you actually have, it's tax-free. It's a portion of your premium, technically called the premium pass-through, that's deposited into that HSA every month. So I'm going to give you another example. If you were single and you decided to choose a high deductible health plan, we'll deposit $6,250 in a health savings account, which is attached to a financial institution. That varies per carrier as well. And that $6,250, you can contribute to it, and it's tax-free. If you come up to that example where you are on Medicare and your plan is converted to an HRA, all the tax caveats go away. What we tell folks and caution them is if you're on one of these high deductible health plans and you're getting or approaching your Medicare age, you really should get out because your health savings account is portable. And what do I mean by that? That means if you disenroll in a high deductible health plan, and let's just say you have $2,000 in your HSA, that's your money. It goes with you. Many folks use strategy with choosing these benefits. I'll give you an example. A young couple came up to me that was on a high deductible health plan. They were starting a family the next year. They were due the next year. What he did was he switched to a traditional plan. So he had a flat copay. He mitigated a lot of out-of-pocket expenses by choosing a traditional plan. Well, he left his HDHP, but that money in his health savings account is his. It goes with him. It's there for you to spend on qualified medical expenses. I get often asked questions, well, if it's my money, can I go buy a Coach bag or a boat? Sure, but you will get a nasty note from Uncle Sam in the form of the IRS. So all the qualified medical expenses are not only out there on opm.gov, there are links on each of our websites that carry those particular products. So, as I mentioned to you before about the consumer-driven health plan, why would you want to choose an HSA or a HDHP plan? Well, if you do a cost analysis of all the 33 plans that are offered to you, the high deductible health plans are the lowest in premium. So they're much less. And let's take it a step further. You remember I said you get $62.50 deposited back? Now think about this. You're paying your premium biweekly, right? You're actually getting money back. So in a calendar year for single, you would get $750 back. Not only that, you can contribute money to your health savings account through payroll deductions or manually at the tax savings. Now, there are thresholds in terms of how much you can deposit in a calendar year, and that is also out there on irs.gov. I believe it's $3,300 for 2014 for single and $6,550 for family. So you can deposit up to that amount in your health savings account. Now, let's take a step back. You have a PPO plan, but you also have a financial component attached to it. On some of the high deductible plans with the HSA, there are 8 interest-bearing investment options on your HSA. For our plan, if you reach $2,000, that comes into play. What does that mean to you? That means that you can accrue money at a tax savings using those investment options, so you can grow that money. So if you were healthy for a stretch of time and you decided to go into a traditional plan, you've got money there to spend on qualified medical expenses. You can apply your HSA to your deductible to reduce that out of pocket. You can also do several things with your HSA. If you want to get LASIK surgery, if you want to get your teeth bleached, those are things that you can use that HSA with. If you've used flexible spending accounts, the biggest difference between the two is an FSA, and I know there are certain laws that are been passed recently that you can carry over money for their FSA, but typically it's a use it or lose it. With your health savings account, it's perpetual. It goes on. It's not a use it or lose it. That money is there. So if you're looking to spend to mitigate a little bit of your out-of-pocket expenses in terms of your premium biweekly, you might want to look at that plan. Don't forget, it's a PPO plan. So you have out and in-network benefits. When you have that, of course, staying in network, you have a greater coverage. But if you happen to need to go see a doctor or a specialist out of network, you have coverage for that as well. A health savings account allows individuals to pay for current health expenses and save for future qualified medical expenses on a pre-tax basis. Funds deposited into an HSA are not taxed. The balance in the HSA grows tax-free, and that amount is available on a tax-free basis to pay medical costs. I'm going to stop there. Most of us give you the option to either have checks or a debit card. So you can actually pay for whatever those expenses. If you went to the doctor's office and you decided, hey, I'll just pay it out of my HSA, you can do that on the spot. To open an HSA, you must be covered under a high deductible health plan and cannot be eligible for Medicare or be covered by another plan that is not a high deductible plan or a general purpose HCFSA, or be a dependent on another person's tax return. HSAs are subject to a number of rules and limitations established by the Department of Treasury. Visit that website for more information. Comparing the types of plans, you belong to an HDHP and use only the providers that's a network. You will usually pay less. There was a part, I'm kind of preaching to the choir here because this is CMS, but a part of the Affordable Care Act is your preventive care is covered at 100% now at a zero copay. That includes your diagnostic and your office visit. Well, these consumer-driven health plans and high-deductible health plans, all your preventive care is also covered at 100% in network. And that was that way before the Affordable Care Act. So those are kind of some subtle benefits that were embedded in these plans that you may not be aware of. Your preventive care is often covered in full and usually with no or only a small deductible or a copayment in accordance with the preventive care guidelines of the Affordable Care Act. So I know I've kind of said a lot. Those plans, I could actually talk for hours about these plans, and we actually have each of us that have carry those products. But the one thing I want you to take away from this plan is these are cost-sharing plans, especially the high deductible health plan that allows you to save for future medical expenses. I will also highlight that if you are someone that goes to the doctor a lot, you're going to incur a lot of medical bills, I would definitely probably steer clear, because those plans are what they're called, high deductible plans. And the consumer-driven health plan also has a slightly higher deductible as well. All that information is out there on opm.gov. And do you have any questions? The latter, not the latter, but the 6,550, for example, is your family maximum contribution amount in a calendar year. It's 3,300 for single, so you can't go over that. Yes, ma'am.
Could you wait?
Oh, I'm sorry. When you said you cannot enroll in the high deductible health plan if you're covered under another plan, would that include like a spouse's coverage?
Yes.
Okay.
So for an individual that's approaching Medicare eligibility, to the extent that they have funds in an HSA, can those funds be used to pay the Part B premium?
Yes. Okay. There are plans that and our plan, Aetna, you would be able to use a portion of that to go ahead and pay your Part B premium. Okay. It is that way also on the consumer-driven health plan as well. So if you take Part B, yes, you could use some of your fund dollars to pay for your Part B premium.
Okay, great, thank you.
Okay. One in the back?
I just want to make sure I got the clarification. If you are of Medicare age,
run for the hills. Do not enroll in this plan. And that's really, and I didn't mean to interject, but if you are around Medicare age, these products are really probably not appropriate for you. If you do the assessment of the other plans and some of the benefits of the other plans, there's no advantage for you to be on these particular plans and you're on Medicare. We counsel, and I myself and my colleagues, we counsel people that carry these products to really be careful about that. Because if you have your HSA and it converts to your HRA, not only do you lose the tax benefits, but if you completely disenroll in that HDHP, you could lose that HRA. That means that money doesn't go with you. It's not portable. So if you had a nice chunk of money in there, you could potentially lose that money. That's why, I'm very adamant with that. If you're around Medicare, you don't need to be looking at that plan. I'm not to say that you couldn't be. We do have members that have been high deductible health plan members for a long time, and they just simply did not move. But if they ever disenroll in that plan, they lose that money.
you've answered the question that I was just about to ask. Thank you.
My pleasure. Thank you.
Okay, I have one announcement. Please use the microphone if you have a question so that the folks who are online can hear. So I wanted them to know that I got their message, and we're going to use the mic. So with that, I'm going to turn it back over to you.
Okay, I think that's it, and we're going to talk about the Federal Employee Vision and Dental Program next. I'd like to thank you so much for your time. I hope I didn't bore you to death. If you do have questions beyond this, I do have business cards, and thank you again.
He does a great job, doesn't he? I think he deserves applause for that. It's a complicated subject. The Federal Employee Dental and Vision Enhancement Act was signed into law by President Bush 2004. This law directed OPM to make available to all federal employees, annuitants, and their dependents supplemental dental and supplemental vision insurance. Are you eligible for the FEDVIP program, Federal Employees Dental and Vision Insurance Program? As an active employee If you are eligible for the federal employee health benefit plans or exchanges, you are eligible for FEHB. It's important to note you do not have to be enrolled in a health benefit plan with the federal employees. You simply have to be eligible. If you are a retiree, you don't even have to be eligible for the health benefit plans. You are eligible for FEHB and can purchase supplemental vision or supplemental dental insurance. FEHB is entirely separate from your federal employee health benefit plans. What that means is you can be enrolled in one carrier's health plan, you can be enrolled in another carrier's dental plan, and you can be enrolled in a third carrier's vision plan. Also, because they are separate, you can be enrolled in your health plan as family coverage, you can be enrolled in the dental plan as self plus one, that's the employee or annuitant plus a dependent, or you can be enrolled in the vision as only self only. Bill did an excellent job giving you an overview of the differences between FEHB and the federal employee health benefit plans. I won't belabor that. The next two slides go through that. We are often asked why the difference in dependent coverage, and it's clear the reason being the FEHB program is governed by that public law, and until the law changes, the coverage for dependents will remain at age 22. So, how do you choose your FEHB program? Well, first, you want to choose your health plan. All of your health plans are going to cover your medical need for your eyes. You don't buy vision insurance to protect your eyes from medical emergencies, such as pink eye, injury to your eye, cataract surgery. Look at your health plan. Almost all of your health plans will offer a discount or even a dollar amount towards your glasses. That's at no additional premium or cost to you. There are very few plans, however, that will pay for a complete pair of glasses and a comprehensive eye exam. So, again, how do you choose your vision plan? Determine what your needs are. If you or someone in your family wears glasses, you can literally save hundreds of dollars by enrolling in a FEHB vision plan. Premiums and copays are important to look at, but they should be the last thing you look at for any insurance coverage, whether it's health plan, vision plan, dental plan. What are you really getting for that premium? What is that copay really helping pay for? So with vision, the first thing you want to look at is your network. Do you have a choice of ophthalmologists and optometrists? And something that I'm often asked, is an optometrist truly a doctor? Yes. Ophthalmologists and optometrists are both doctors. The difference is your ophthalmologist specializes more in the medical care of your eye, the optometrist for the routine care. Does the vision plan you're looking at offer a choice of private practice, the Dr. Sally Joneses of the world, and retail chains? Is the doctor you're currently going to in your network? Or can you even go out of network with that plan? You want to look at what is covered by the plan. With the FEHB programs, every vision carrier will offer you an eye exam and a pair of glasses, or contacts, not both or. The difference besides the premium and copays is going to be the frequency that you get your eyes examined and your glasses, the lens options that are covered, and the contact lens coverage. You want to compare what is not covered under your insurance. All of us that wear glasses know how expensive those add-ons can be. We all get sticker shock when we go to the cash register because it's like, what? So look at what is not covered. Are you guaranteed price protection? In other words, you know exactly if the insurance is not covering your AR coating, your anti-reflective coating, do you know exactly what you're going to pay for that? Or is the plan simply offering you a discount off of retail? After you do that, then you want to look at your premiums and your copays. Everyone's talked about using OPM to compare plans. I would like to also offer you, if you haven't heard of it, plansmartchoice.com. This website is only for federal employees. It is under the guidance of OPM, so this is not done by a particular carrier. You're not going to be directed to only a specific insurance carrier. You're going to be able to look at your health benefits. You're going to be able to compare your FEHB carriers, and FSA, Feds, is also available at this website. So if you haven't heard about it, please spend some time out there before open season. I think you're going to find it's very easy to navigate. You can line up all your plans that you're interested in, and you'll go right down through and compare the coverage. You have questions on eligibility or retirement, you want to go to your Human Resource Office or opm.gov. And to enroll in FEHB, it is not done the same way as you do your health plan. You can only enroll in FEHB, both dental and vision, by going to benefeds.com. I'm going to turn it over to Tamika, and Tamika will talk to you about FEHB dental plans, and then we'll take questions that you may have. Thank you.
Thank you, Sue. I'm going to highlight some of the benefits for the dental portion of the FEHB option that's available to you all. The FEHB plan is fairly new, and I like to say that a little loosely because it's been administered for about the 7 years now. And we're actually physically in the 8th year that the plan has been in existence. It's a separate plan, and it's different from your FEHB medical plans. It's actually pre-tax payroll deducted, just like your medical plans are. And federal retirees are eligible for the FEHB plan as well. You all as members, you do pay 100% of the premium. The government doesn't subsidize the FEHB plan like they do with your medical portion, which they usually do about 74-75% for your medical. So it is funded by you as the member with the premium 100%. We do have a 3-tier rate structure. You will find a self plus one, and a self and family, which we were indicated earlier. There are 4 national plans that are available, and they do have out-of-network benefits. And then most of the plans, there are no deductibles, and I like to say that a little loosely. All of them pretty much, there's no deductible. Only waiting period will be for orthodontic care, and you can utilize really any dentist in the national plans. So again, you have to check. This will vary from provider to provider, what the waiting period is on orthodontics. And a lot of carriers also, it's not only orthodontics for children. We made a lot of changes that a lot of the carriers actually cover medical needs for adult orthodontics as well. So again, like Sue was indicating, you can mix and match your plans. You could have one carrier for your medical plan. You can have another carrier for your dental, and then a third option, again, for your vision plan. So you can have 3 different carriers taking that pre-tax payroll deduction for your health and medical benefits. There's a 4-tier benefit structure in the FEHB plan, and it's displayed by percentage. There's 5 national plans and 3 regional plans. You'll find it broken out in the benefit checkup, where first will be your preventative. You'll have intermediate. You'll have your major dental work that you need, such as like surgeries, caps, crowns, dentures. And then the 4th tier will be orthodontics, which is braces. Now, you do want to check out with most of the carriers. They will have an orthodontic lifetime maximum and an annual individual maximum as well. So that's going to vary from carrier to carrier. Again, this is a plan design example. And again, like we said, we break up those dental services pretty much in a 4-tier structure. We have pretty much the A class of services, like I said, that's your preventative, and that is your routine cleanings and your 2 bite wing x-rays you receive once every 6 months. Now, you will have a standard option that's available to you and a high option that is available to you as well. And again, like I was saying, there was no deductible. Pretty much you have to look at these as a percentage-based plan. So the higher the option you choose, the less out-of-pocket you're going to pay on the back end. So, for example, preventative is covered 100%, whether if you choose the standard option versus the high option. Now, where you start utilizing some of your money is actually in Class B. And that will cover your fillings, your extractions, your periodontic maintenance, which is like deep cleanings that you have to have in the dentist office. If you choose the high option, it will cover 80% versus it only covering you for 55% on that standard option. So like I said, the higher the option, the less you're going to have to pay on the back end. And C class of service is pretty much your major restorative, like I said in the previous slide, is that it's going to cover your root canals, your crowns, your bridges, your dentures, and your oral surgeries and things of that nature. So the high, it will cover a 50% up to the plan's benefit maximum versus 35% on the standard. And D class, again, is the orthodontics, is braces for adults and children. It's 50 and 50 on both of those plans. And to enroll in the FEHB option plans, you can log on to www.benefeds.com, and all of these plans are available during open season or not unless you have a qualifying life event. And you can call toll free if you do run into a little technical difficulties on the Benefeds website, and that information is available, which is 877-888-3337. So again, just like I said, this information is also available to you as well to do a plan comparison of the plans, the dental option and vision options that are available to you on opm.gov/healthcare as well. So I guess now we're just going to open it up and see if you all have any questions. Is there anybody who has any questions?
Question about this dental care. On the high option, since I'm trying to understand if you're under Medicare, do they take any dental portion under that high option?
No, no, that's totally separate. You might be trying to confuse that with your, in the health plan, but the dental, it doesn't coordinate with your Medicare. What? Bill. It doesn't. Yeah, Bill got the portable.
Bill got the portable.
Bill got the portable.
If the dental coverage, for example, there's an accident, is covered as medical,
right, then
it will coordinate with Medicare. But we're talking about routine dental care. Medicare doesn't cover that either. That's the difference.
What I'm trying to understand and get a clarification, I want to get FEHB for dental work.
Yes.
Right? I am a federal government employee, so I'm able to get that now.
Yes.
Oh, yes. Mm-hmm.
And you can carry it into retirement.
Your retirement. Yeah.
Okay, that's what I wanted to do.
Yeah, there's no as we said, there's no 5-year rule, and so you can pick it up and drop it. And retirees have open season during which they can pick up and drop the dental and vision as well as the medical. They don't want to drop the medical, but they can drop the dental and vision if they want.
Right.
And come back 2 years later.
And come back and pick it up. So you'll have open season just when you retire, just like normal now with you being an active employee. So
I can actually get it right now. I'm getting ready to to apply for it. That's my question.
Yeah.
Like today.
She's filing today?
Yep. I don't know what open season is.
Are you applying for FEHB into your retirement?
Yes.
You have to wait till open season to do that. You're not carrying it now while you're active, are you?
I'm active, but I'm not carrying it at this time.
Okay, well, then you'll have to wait till open season.
Thank you.
Yep, you'll have to wait till open season. Yep. Okay, now we are actually going to move forward with the presentation, and who's going to take Bill? Again, thank you all for having me. I represent GEHA Medical and Dental Plan, so if you have any additional questions, please feel free to ask me, and I do have business cards available as well. Okay, we have one more question. Go ahead, sweetheart.
Can you explain how FEHB covers dental or vision after your medical provider that you have? Say there's some benefit, there's some dental.
All of us
how
here.
Do they pick up and cover that after the medical has paid their portion? How do you guys decide what's
Right.
covered?
Well, what happens is with all of us here, we all have some type of preventative, like you said, dental built into your medical plan, whether if it's a discount amount or a dollar amount. We take that off of it's primary. Your FEHB medical portion is always primary, and then it comes over to your FEHB dental plan that you have chosen. We actually take it based upon after they paid what that amount is.
Can I add one thing to that? Is that not all dental carriers pay the same after medical.
Right.
Some do traditional coordination of benefits, which means whatever's less, what they would have paid, or the balance they will pay. Another carrier may subtract out the payment made by the medical plan, then do their 50%, so let's say for something afterwards. So you need to find out, we call coordination of benefits guideline with the carrier you pick, how they actually do that.
Right, and that's something that, you know, it's pretty much done electronically between the carriers. You see what I mean? Where the members don't have to really get involved in that portion of it. So that should be seamless to you. So next we're going to turn this over to Bill. Bill Gray's going to continue on with some of the non-FEB questions and things of that nature.
Okay, we wanted to take a couple minutes, and I'd stress that, to discuss some things that are not necessarily part of your medical benefits. First is flexible spending accounts. You know, there's different types. We're really concerned about medical flexible benefits, for medical benefits. As Sekou mentioned, they are use or lose. There is now a carryover. I think the federal government's actually going to go with this next year. I think it's up to $500 you can carry over. But as he said, it's basically use or lose. If you have, let's say, a traditional plan, the PPO, and you find your deductibles and co-insurances, you may want to look into an FSA. Keeping in mind, every one of the carriers, you can find out how much of the catastrophic limit, that's the maximum out of pocket, you have satisfied during the year. Use that as a guideline. If you see for 2 years there's a pattern, I'm spending $600 or $1,000 out of my pocket every year, and that doesn't include dental, you may want to consider a flexible spending account. It's your money, and it's pre-tax. Healthcare spending account, that's the one I'm going on. I'm not going to go through these in detail, but this gives you an idea of who is eligible and what it covers. And again, it's defined under the tax code, which you can pay for. Limited FSAs, Sekou covered these. That's, I have a high deductible health plan, I want to set aside money for dental and vision. Dependent care accounts, these are different than just for medical, and these are for any child or children up under the age of 13. You need the tax ID to claim the money back. That's the important thing. So if your sister's watching your child, make sure she's set up with a tax ID. Under non-FEHBP, what are they? These are these benefits that if anyone's ever studied the brochure of any carrier, it comes at the end of Section 5. That's where benefits are. And it talks about those other things we offer you because you're a member. Under these non-FEHBP, you can find all kinds of stuff. They're not regulated by OPM mandates. They're extra benefits. And they're available through associations or the carriers. And they can include a lot of things. They can include discount membership to a gym. They can include legal counseling. They can include discounts at Reeboks. These are the things that are really important to you as members. They could be, like I have one plan, that gives you a discount on dental, but it's not part of the medical contract. It's something you get because you're a member. So you really need to read these carefully, see what things are interest me beyond my medical, what things we do to keep you healthy and active, and you will find them under the non-FEHBP section. Okay. Any questions on anything we covered so far, dental, vision, or non-FEHBP? Keeping in mind, we're going to be around till 3. Yes, sir. Ma'am. Yes, ma'am.
Yeah, the flexible spending account, why did they, I guess my only negative with the ACA is that they halved how much you could put into the...
Most of that's IRS regulations. I can't address those, but they do have...
had been with part of the ACA because that's when it...
Oh, it's not part of Affordable Care Act. This is something that's IRS regulations. So they're totally separate from anything that...
I know, it's just for 10 years or 8 years, 5,000 was the amount, and all of a sudden...
Oh, why did they...
And have it.
I can't answer that, why they cut it. I'm sorry, that one I can't answer. Any of you guys have an answer for that? IRS. The answer is IRS, not us. Yes, ma'am.
I may have missed this, but can you roll these over into retirement? Or can you use them in retirement?
FSAs are only when you're active.
Okay, that's what I thought.
Yeah, it's the same thing when you retire. The other thing we don't talk a whole lot about is right now your health premiums are pre-tax. Once you retire, they're not pre-tax anymore. They're post-tax. So there are things that happen when you retire, and that's just not the federal government. That's everybody. Because I know there's a move to try to get federal employees to be able to do that in retirement. You got everybody else saying they wish the same thing, so require some changes in the IRS. Any other questions? Okay, I'm going to turn it over to Linda Anderson. She's going to tell you some things about long-term care.
Good morning. Coming down to the home stretch here. My name's Linda Anderson, and I am a long-term care insurance specialist, and we're going to do long-term care 100 as opposed to long-term care 101. So very brief. So what do we mean when we say long-term care? What is long-term care? We've been hearing all morning about your health insurance plans. And let me just start off by saying long-term care is not health care. Focus on the word care as opposed to cure. Your health insurance provides and pays for services associated with helping to cure you. You're going to get better. Long-term care, it really is just help getting around. We refer to this as custodial care or informal care. We also talk about activities of daily living. So these are the things, think of what you do when you get up in the morning. You get out of bed, you get to the bathroom, you get yourself into the shower, you dress yourself, you get your meals prepared. So long-term care is helping people that are no longer able to do those things. Custodial care, not skilled care. And these people that need this kind of help, it can be as a result of an accident, injury, illness, frailty. And don't just think it's confined strictly to the senior population. In fact, a good portion of the people receiving long-term care in the country today are actually working age adults between the ages of 18 and 64. People also might need care or supervision because they may have a cognitive issue. So they might be able to get up and get into the shower, but it's not safe for them to be there by themselves, or they forgot why they're in the shower. So why is it referred to as long-term care? Health and Human Services defines long-term care as custodial care lasting 90 days or longer. And where does long-term care take place? Well, we call this the broad continuum of care. Some people call it aging in place. Long-term care, you might be thinking, visualizing somebody in a wheelchair at the end of a hallway in a nursing home, when in fact, guess what? Most long-term care nowadays is taking place in the home. Most people want to receive care in the least restrictive environment possible, surrounded by their loved ones, their family members, and that is typically going to be in the home. However, long-term care also can take place in the community, adult daycare centers. It can take place in small group homes that you see in your areas where you live, assisted living, places like Charlestown here, continuing care retirement communities, we call that. And then last but not least, long-term care takes place in a nursing home as well. And why is it important to plan for long-term care? Well, the good news is that we're all living longer, and that also happens to be the bad news, because the longer we live, the greater the likelihood that we're going to have some kind of long-term care event that could happen. You know, the average life expectancy at the turn of the 20th century was 46, and now it's 78. And the things that used to kill us now we're able to survive, like heart attack, cancer, stroke. So these are all the reasons why we're living longer. And the cost of long-term care is very, very high, very significant. So you need to take a real hard look at where would the money come from if you or a loved one needed care over an extended period of time. And we've heard thus far all about these different choices that you have with your health insurance, and you all know, because again, preaching to the choir here, your medical insurance and Medicare does not pay for custodial care. So actually you will see that listed under exclusions in your policy language. So that's why it's important to take the steps to develop a plan, and the plan might or may not include a long-term care policy. But we spend our entire working years trying to grow our nest egg and plan for our retirement. And doesn't it make sense to take the steps to protect that nest egg should a long-term care event take place? And we're going to talk a little bit further about the actual cost of care. I've already mentioned that the majority of care now is taking place in the home. And guess who's providing most of that care? Informal caregivers, predominantly family members. And we know that long-term care doesn't just affect the person that actually needs the care, it impacts the entire family. There's a saying in the industry that long-term care doesn't bring a family together. It can many times tear a family apart. So what are the costs? I will tell you that this is a chart that is showing, it was based on a cost of care survey done last year, and it is based on average costs nationally. So do you think that the DC, Baltimore metro area fits into the national average when we talk about cost? No, unfortunately we are in one of the higher cost areas when it comes to long-term care. So this chart breaks down costs for semi-private room in a nursing home on an annual basis, assisted living, and then home care. In this area, we are really looking at closer to over $100,000 on average for a semi-private room in a nursing home. About $300 a day is not uncommon. My mother-in-law was in a facility in Rockville about 2 years ago, and it was over $9,000 a month. Assisted living, again, national averages here. In the DC metro and Baltimore metropolitan area, you're looking at ranges anywhere from about $4,500 a month to about $7,000 in the case of Oakcrest, if anybody's familiar with some of these assisted living facilities. I looked that up just before I got up to speak because I just got a new publication that tracks the cost, and that's up to $7,500 a month. So these are costs that are closer to $70,000 a year for assisted living. And home care, I call home care the great unknown because home care can be less expensive than if you're in a facility, but a lot of times it can be more expensive than if you're being cared for or a loved one is being cared for in a facility. And that is because this is a figure here that we're looking at that is representing 6 hours of care 5 days a week, where you're paying for someone to help take care of a loved one. My question is always, well, if somebody needs help bathing and dressing themselves at 8 a.m., don't they also need that same help at 8 p.m.? So who else is in the picture to help take care of the loved one? Are there family members? We call that a support network. If there are a lot of family members or friends, loved ones that are in the picture to help fill in for those other hours, then it is certainly conceivable that you might only need to pay for outside services a few hours a day and maybe not even pay for someone on the weekends. But you can see where if someone needed round-the-clock care and did not have a support network, that you would then be looking at figures that are actually many times higher than if you're in a facility. The Federal Long-Term Care Insurance Program, which we affectionately call FELTSIP for short, is a comprehensive program that covers you in all of the sites of care that we've talked about. So home care, daycare, assisted living, small group homes, continuing care retirement communities, and nursing homes. The plan has a lot of flexible language in it, language that you don't always see in some of the other policies that are out there in the private sector. There's a lot of leeway given in terms of who you are allowed to use and pay for your home care, for example. The plan will pay for informal caregivers such as family members and friends. There's a lot of other benefits built into the policy, things like care management services, and these are people that are nurses that kind of serve as your quarterback at the time that you or a loved one needs care. So invaluable services that are built into the policy. Now, this is where we get into a lot more detail, and I don't really have the time to go into it standing here, but I will be around this afternoon. But basically, let me just kind of cut to the chase and give you just the basics with designing a policy, because you can truly design and customize your own long-term care policy, whether it's this policy through the federal government or another policy that you might look at from a private carrier. Your premium is going to be based primarily on your age at the time that you apply, and that's why it's important to remember the one thing that I would say to take away from this is that you can apply for this coverage at any time. It's not relegated to the open enrollment season. Because your premium based on age at time of application, and then beyond that, you can customize your policy based on your own particular financial objectives. So what is it that you're trying to achieve? How much coverage do you feel is adequate? How much will your budget allow? You look at these three areas when you make it when you're designing your policy. First, you're looking at the daily benefit amount, and that's the amount of money that the policy will reimburse you on a daily basis. You can choose anything from $100 a day up to $450 a day in $50 increments. The higher your daily benefit amount, that will drive your premium higher. So how do you arrive at a decision? People always ask me, well, I don't know how much coverage to get. Well, you look at the area, what the cost of care is in your area where you live or perhaps where you're going to retire. If you're retiring to Georgia or South Carolina, cost of care is lower there. If you're here, then you look at the cost here. And then you also take into account the notion of self-insuring. When we purchase other types of insurance, we always have some co-insurance. The same would hold true here, and that helps to keep your premium down. So maybe you transfer a portion of the risk to the insurance company, say 75%. So these are all things you can take into account. The benefit amount or the benefit period is the length of time that the policy will pay out once a claim has been filed. You can choose anything from a 2, 3, 5-year benefit period all the way up to a lifetime unlimited benefit. And the longer the benefit period, the higher the premium. Again, people constantly wondering, well, how do we arrive at a decision as to what's appropriate benefit period for me? And I tell them you can look at things like, is there a history of longevity in your family? Is there a history of something like Alzheimer's in the family? But when it's all said and done, believe me, your budget will probably dictate, and that's certainly reasonable too. You can also look at statistics. There's lots of statistics on the websites, lots of good information out there. And then finally, inflation protection. You want to decide how do you want your benefit to grow, because the policy that you're purchasing today is not going to, the amount that you're purchasing today is not going to mean the same 20 years down the road, 25 years down the road. So you have options when it comes to what type of inflation. And the biggest factor that drives the choice that you might make with inflation would be your age at the time that you're taking out the coverage. The younger you are, then it's more important to have good, solid inflation coverage built into your policy. And let me just talk briefly about some of the strengths of the FELTSIP plan. The first being that you're purchasing it through the federal government, so there's a lot of consumer protection features built into the plan. It's the largest long-term care insurance program in the country. There's over 270,000 people enrolled to date. The program rolled out in 2002, so we're in our 12th year. It's underwritten by John Hancock Life Insurance, A+ rated company with a long history in long-term care. They got into the business in the 80s, so they have not just actuarial experience, but claims experience as well. Office of Personnel Management has oversight over the program, and some interesting features are that the premiums from FELTSIP are held in a separate fund called an experience fund, totally separate from other John Hancock assets. The profit that Hancock can realize is capped, and there are performance matrix that John Hancock or the program must meet in order to achieve those types of profits. And because there's no commissions paid to any sales representatives, we're able to pass that savings on to you. So the most important thing to remember once again is that you can apply for the coverage at any time. And it's important to get it, I have a saying, apply when you're young enough to afford it and healthy enough to qualify for it, because you do answer medical questions on the application. Your qualified relatives can apply even if you choose not to enroll in the program. So that's important to know as well. You each are applying individually, so you're each applying based on your age and your answers to your medical questions on your application. This is a truly portable benefit. You can take this coverage with you, and your premiums can be payroll deducted, and then once you retire, it can be taken out of your annuity. So what are the next steps? I have some material here with me that I'll have this afternoon at my table. There's brochures. You can go online. The website is totally transparent. Lots of information on that website, lots of numbers. You can get in there and really crunch some numbers. Lots of statistics about, and there's interactive tools. There's the cost of care information that gives you care, how much care costs throughout different parts of the country. If you want more of a personal approach, you can call one of the certified long-term care consultants. They are happy to help you. You can ask to have a packet mailed to you. You can even fill out an application online, or the certified long-term care consultants can also help you with that as well. And I would end by just saying that the important thing to do is take the step to plan. It should be incorporated into your total retirement plan. And again, whether or not it includes a long-term care policy, or perhaps you've addressed the issue and we've sat down, we've discussed it with our family, our loved ones, and we know that we've got a plan in place. So that's the most important advice that I could give you, is to take the steps and to come up with a plan. Thank you very much. Are there any questions?
Are there, like, what do they call them? When it kicks in after 90 days, that kind of stuff. I'm trying to think
Right.
what they're called.
That's called a waiting period or an elimination period, and there is a 90-day waiting period. Any other questions?
Yes, one more.
I thought I read something about this at one point, but are there any options, like if two spouses are enrolled, that there would be an option that one could, I mean, just guessing that maybe one of two may at one point need long-term care coverage, that it could be shared? Is there anything like that?
That is an option that's available, not in this particular plan. In the private sector, you can find policies that offer that as an option. I think that's a very good option for couples to consider, because it allows the couples to look at the coverage together. But it is not something that's offered with this program. Thank you.
Okay, we now open it for general questions. I encourage the people on the phone, if there's people still out, they call first, because the rest of the folks have us here till 3 o'clock. Okay, so if any other questions?
If you have any questions on the phone, please hit pound 5. Again, questions over the phone, please hit pound 5.
Okay, we want to thank you all. Oh, you had a question? Yes, ma'am.
Yeah, I have a question. I used to work in the private sector, and we used to have this product called short-term disability insurance. Is that offered in your non-FEHB products?
That's a whole nother question. It could be. I think that there's at least one carrier I know who does have something like that, but they're not offered here. The government has its own disability requirements. Say again?
There is some kind of short-term disability. I think it's called Fed Advantage. I know I'm enrolled, and it's not one of the official OPM things,
right?
But I do get it
deducted from my
paycheck.
There are affiliated groups that permit payroll deduction. They're not part of what we do.
Yes, that's through EAA, and you all can talk to your benefits specialist to get additional information on that.
I know we've been some new employee meetings where they've actually invited people in, the agency has, who offer these type of coverages. Yes, ma'am.
My question is still pertaining to this FEHB under vision and dental. Who would I speak to after this about that? I really need to talk with someone about
Actually,
this.
FEHB,
Totally.
to those of us who are here, if you want to talk to privately, would be Tamika has dental, Sekou has dental and vision, and I have dental and vision. And of course, Sue has vision. You know, I can't leave Sue out. Okay, so there will be dental and vision carriers with us this afternoon. And there are actually some that offer separate vision and dental you can buy outside of FEHB. And Kelly can tell you about that.
Yes, you can come back. They will be here until 3 o'clock. So we're going to be over in the multipurpose room. Okay? And you all can just come on over there because we have to leave out of here at noon. So you can come over and speak with the reps at the multipurpose room.
Okay. Any other questions?
Okay, so we don't have any other questions.
And we appreciate the opportunity. Thank you.
Thank you. This concludes our presentation.